This is a case that's super requested because I've had so many people ask how I do IPR, and I show this case often when I am doing my IPR segment as an example of what I did on the lower incisors. So I want to show you how we treated this case because, again, it's just every single time that somebody sees it, they want to know. This patient here, she comes in and she's 14 years old. The first thing to look at is that her molars are pretty much in like a class 1 occlusion. She's maybe a little bit class 3 on this side. Hard to say with all the crowding. Obviously in the anterior, she's got a pretty significant, she's got some pretty good crowding there. So we recognize that we've got crowding, we've got crossbites. She's a little bit class 3 and she does have a bit of growth. Now again, I don't expect all of you watching this right now to say, oh yeah, I know exactly how to interpret cephalometrics for both facial as well as for the C-spine. So when we look at her situation here, we can evaluate CS2, CS3, and see that her spine, so for those of you who are in Toronto, you'll hopefully understand this here, she's starting to get a concavity and she's had elongation of these vertebrae, which means that her growth is mostly finished at this point. There's not going to be a lot more that's going on. But we know based on her age being 14, and she's a little bit class 3 here, she is still going to have some growth occurring. So she's not completely finished growing. When we look at her face, we can see that her lips are more protrusive and her chin is a little bit more retruded. And so in terms of treating this case, we need to be aware that she's going to still have a little bit more class 3 growth. That's going to come up as we get into the clin check, but it's just something I want you to think about right now. On the upper, she does have one primary canine that's still hanging around that we should turf and get out of there because it's causing this canine to erupt atypically. And you'll see that biting us in the butt. I was talking about mistakes. I will show you a mistake that I make on this case here, and it has to do with this canine. So I'm going to make an error, and it's something that I critically look at after my case, and I say, how do I do better next time? Even though I think the results of this case are great, I want to be better next time. We have to turf this primary tooth. An important thing to know is that if you have asymmetry in the eruption patterns of teeth, right? Let's say the other canine was at the same height and looked very similar, I probably would not be too worried. But because this canine is higher up and the other one's already down, this is delayed eruption now. So let's get this baby tooth out of the way and make sure that it erupts in the best spot possible, and then we're gonna have to go ahead and address that position and make changes. So there's our initial assessment. Let's go ahead and look at treatment plan number 1. So like I said, we need to be aware of her class 3 situation. We always want to go ahead and check out this Bolton analysis. Super, super important. So we look at our Bolton here and we see that she doesn't have a significant Bolton, right? It's only 1.15 millimeters. At what point are you more concerned in a non-growing patient who's in class 1 that you should do either IPR on the lower or leave spaces for buildups on the upper if, again, non-growing class 1 patient? The answer, 2 millimeters. So we're less than 2 millimeters, but when you look at this case here, right, we evaluate, you kind of go, okay, yeah, she's a little, like not a little, she's tight, right? We're a little bit class 3 on this side here, which makes things a bit worse. And we've obviously got the crossbites, the crowding, everything going on. So in this situation here, we're gonna wanna make sure that we recognize the fact that this is a moving target. Where we are right now is not where she might be at the end of treatment. It's not like her jaw is gonna grow a tremendous amount, but she might have some late growth. And so we need to be aware of that and we need to take some precautions. So what precautions are we gonna take? Well, we should be prepared that we may wanna go ahead and use some class 3 elastics, right? We're gonna plan to use some class 3 elastics going from the buccal of the lowers to the lingual or palatal of the uppers. Well, Stephen, why go from the buccal of the lowers to the palatal of the uppers? Well, the reason is that when we go from the buccal of the lowers to the palatal of the uppers, it's gonna cause some expansion to occur. Because when we look at the arch, we can see that she is a little bit constricted. Look at the position of the second molars here. And maybe actually let's go back to her photo here. And you can see there's some constriction in the arch at the 6s, and then there's more widening has occurred at the 7s. And so with those 6s being a little bit constricted, we wanna go ahead and we wanna expand those arches a little bit more. Okay, so we have some arch development occurring with some expansion. We've got some buccal root torque. How do we wanna orient these attachments? Right, a nice retentive edge on the 6 and the 5, right? This is going to give us a really good grip of the tray so that things are going to fit as long as you make sure you clean your flash out from here. You don't want this flash to cause the tray to lift up and not fit. In contrast, if I was doing this again, this is a mistake on the 7. The 7 should be pulled out further and beveled slightly towards the occlusal to give us a better retentive aspect on that attachment. Check out the other side. So good on the 6, good on the 5. Wait a minute, what are we doing on that 7? We don't even have an attachment on it. Is that tooth moving? Absolutely, that tooth's moving. And we're putting torque into it, right? We're moving the roots more towards the buccal surface here. So this is problematic, right? This is an error. This is going to result in that tooth not truly expanding. And instead, it's going to be probably experiencing a tipping movement, right? So you need to have the right attachment to go with this tooth. Well, we've planned in on the lower, those class 3 elastics, and we do have them going to the lingual, because when you go from the buccal of the lower to the lingual of the upper, the elastic is going to help with some of the expansion. So that's really beneficial. So that's why we don't go buccal to buccal here. You could go slit to button if you wanted to. In this case, we just go button to button, but you could certainly go slit to button. On the lateral incisors, what do we say about lateral incisors? Really always want to have an attachment on those lower incisors. Upper incisors, upper lateral incisors, right? Because they're small teeth, and even more so, look how small this lateral incisor is. There's so little tooth structure for the aligner to grip at the very beginning. This is a challenging movement. And so we need to make sure there's an attachment on that tooth. How do you place an attachment on that tooth? You go ahead and use your 3D controls. You grab it, you drop it, you place it on yourself if you want, or you ask the technician to do it. I haven't used that ClinCheck recently enough, so it's frozen on me. One more thing that we did here is we actually asked the technicians as that tooth is moving to make sure that this tooth has 0.5 millimeter of space between it and the neighboring teeth as it moves past them. Friction is the enemy. If this tooth starts butting up against the neighboring tooth, it's going to stop moving. We want this tooth to fully move buccally, and then the space can close. So all we ask the technician, please ensure 0.5 millimeter of space between the upper left lateral incisor and the upper left central, the upper left lateral incisor and the upper left canine as this tooth moves buccally. Then close the space when it has moved completely to the buccal. Or when it's finished all of its buccal movement, then you may close the space. It's such a minor detail here, but it makes such a significant difference in terms of being able to have this case track and work properly. Okay, let's look at our lower curve of Spee, right? Common things we keep coming back to, right? Do we have a Bolton discrepancy? Do we have a curve of Spee? Do we need to move a tooth that's blocked out and have some space around it? Do we have the right attachments to help intrude this curve of Spee? So we do have a little bit of a curve of Spee. We're not super deep at the beginning. We're not great, but we're not super deep with this curve of Spee, so we didn't really overdo it like we did that last ClinCheck. We kind of just flattened things out. But these attachments are really great. They're really retentive, and what's going to benefit us here in this situation is whether we're using these attachments, the conventionals, or whether we used optimized attachments that were really thick and juicy. The main thing is that I want to plan this case to reuse the attachments. I don't want to change them out every single time. My biggest pet peeve in life is, I should say, an Invisalign treatment. Number one, what I hate is when IPR shows up at 10 different points. Let's go back for a second again, just because I'll show you that I made sure that IPR happens once when the contacts are derotated and there's easy access, and I'll show you how we do the IPR very shortly. IPR happens once, all at the exact same time, interproximally between the teeth, not on the buccal of one tooth and the lingual of the other tooth. Pet peeve number 2 is going to be changing out attachments. My goodness, how much do I hate sitting down and drilling off those attachments and the patient's white knuckle in the chair, just in so much sensitivity and discomfort and pain, and then to be told that we're putting them all back on 2.5 weeks later. It's a terrible experience for everybody involved. Nobody likes it. I tell some of my patients at the end of treatment, when we've only changed up attachments here or there where needed, normally the protocol would be to shake off the attachments every single time and replace them every single time, and they look at me like I'm crazy because they're like, that is so uncomfortable. I agree. And it's also a complete waste of chair time. So in every case where possible, I try to plan my attachments intelligently. That means that you have to know how to change the attachments if you're going to do that. You can't just accept every single attachment that comes back and leave it on for the next batch, because sometimes the attachments are really, really small. They're not the right attachments. Yeah, like for example, this lower canine tooth here, we did change out that attachment for let me go to the final one here. So I changed this attachment, for example, in the last case, because I knew that this attachment is so small and will get so worn down. And so I would rather have something that's bigger and more robust. so that I can leave it in place at the end of this batch. So when you see this attachment for the next set, it's great. The trays are actually gonna fit even better than they did before because that's gonna fit so well. And again, it doesn't mean that you have to use conventional attachments. You can go in there and you can place a large optimized attachment on the tooth as long as it's the right attachment. The surface area that's being pushed against is in the right spot. If I can leave the attachments on and not need to change out every single one every time, that is 100% my preference. You can only do that if you actually understand how attachments and the biomechanics of the tooth movements work. You can't just go ahead and change it. Like I just had this 2 weeks ago. Someone changed a lot of attachments, but they put them on the wrong orientation. And then they're like, hey, Steven, you should be really proud of me. Like, look, I changed all the attachments. I left them on. This isn't working though. This case is not working the way it's supposed to. And the reality is that the software has so much knowledge in it of what is effective and works with the optimized attachments. It's just that any of the small optimized attachments are only active and only function really well on that first round. So you have to take them off and then replace them again. But if you can go ahead and plan it intelligently, then you can take control and you can make your own decisions. But you can't just go in there and willy-nilly change everything out and not have a plan. So here's the small optimized rotation attachment that I left. I should have replaced that for a conventional or an optimized expansion attachment. Thing here. I don't think I showed this on the last one. If I did, I'm just repeating myself, but on the lower, right, I changed this out for a conventional attachment. This one has great surface area to it. It locks in beautifully. The original plan was that this was going to be an optimized rotation attachment. Did not like it. So we can make that change. I'll go ahead and just show you what it looks like on the next round, right? Like look at this attachment now. This optimized rotation attachment is kind of just a bit of a blob. It doesn't have a great surface here on the gingival aspect to help with our torque. This one here on our first premolar is great. On our second premolar, we did a terrible job cleaning up the flash. And then remember this one? This was the attachment on our second molar that we didn't bevel nicely, right? We should have beveled towards the occlusal, and you can see that we don't have a good surface here to grip onto. There's no retention. And so that's part of the reason that you're gonna see some struggles with figuring out the torque and getting the bite to settle. Let's wrap this up with the first clench check. I was just saying that we have some unfilled occlusal attachments on the back. These are just to help prop the bite open so that she doesn't hit so heavy on those posterior teeth. Okay, I wanna show you a little bit about IPR. Not gonna take this too long. I get asked this so frequently too. This is probably question number one, and this is where people see that case from. There's 4 different methods of IPR. Hand strips, discs, reciprocating, and burrs. Hand strips are foolproof, but they take forever. You have to work your way up through the series. It feels like you're trying to start a fire.
Hi guys,
right? You probably know enough about these already, but literally just back and forth, keep working up one series to the next series to the next series. They're also super, super, super expensive. Cost of IPR quick strips is $8 per strip, meaning that if you're going up to 0.1 millimeters of IPR before jumping onto a space file, you're looking at $41. With space files to go up to 0.5 millimeters of IPR, it's another $186. You're looking at $227 to do IPR. If I had to choose to do something of IPR that's like 0.1 or 0.2 millimeters, I would use a Vision Flex strip, and that would be still $25 per strip, but it's actually a lot cheaper. To me, interproximal reduction with rotary is the scariest way of doing it. The wheel of, because why is it so scary? It's a nose cone. When's the last time you used a nose cone? Right, and every surface on this nose cone, on this reciprocate or circular, it's cutting. It's cutting on the end and it's cutting on the sides. Everything is cutting here. And so if you get the orientation wrong and you're not in the perfect plane, you're gonna end up causing more removal of tooth from one side from one tooth versus the other. If you go too far and you hit the gingiva and the papilla, you'll cut it. Or, so this is what it looks like if you accidentally ledge a tooth. One tooth is damaged more, has IPR that's been done to it more, and the enamel's completely gone and that was a virgin tooth. Or what's truly terrifying is this was with that pizza disc. If you slip, it will cut tissue. It will cut your finger, it will cut the lip, it will cut anything that it comes in contact with on every single surface. And it's a nose cone, which you are not used to using. And so this is on a teenage patient, obviously a significant lawsuit, plastic surgery required. It's horrible. It's absolutely nauseating to me. So that's why I have those in my drawer. They're super cheap. I will not touch them, to be honest, because that scares me. Interproximal reduction can be done with a reciprocating handpiece. This is what Terry uses. They're really great for being conservative because they're non-end cutting, right? You go up through a series of them. They reciprocate back and forth. It's on a slow speed. or its own handpiece. It is a little bit more vibration, but it will not cut tissue or anything else. And you work up through a series of them. So that'd be kind of my runner-up. The one that I would use though as my primary means of IPR would be to use a high speed. I would not use this burr. This is the reason that dentists use those other methods, because this burr tapers. It comes to a point. So don't use this burr. The burr that you want to use is very specific. It's from Strauss. It tapers to a point, it doesn't taper to a point, it's parallel. So these surfaces here are pretty much parallel with one another, and they're exactly the size that you need them to be. So this burr is exactly 0.4 millimeters in width, and this one is exactly 0.3. And because of the tapering, you can maintain the embrasure space. From Strauss, so Strauss diamonds, they cost $20 for a 2-pack, so they're $10 a burr. The number of doctors who've come to me and said that these burrs changed their life is so many. I probably have like 50 doctors who come to me and said that these burrs make them actually enjoy doing Invisalign, because now they don't feel like they're trying to start a fire in the patient's mouth. So how do these burrs work? So you can start underneath the contact. You guys won't have sound, unfortunately, just with how it's playing right now. But essentially we started underneath the contact. We break through the contact, we come back and we go parallel to the tooth. And exactly 0.4 millimeters of IPR was done in this situation here. Starting below the contact point, just letting the burr do the work. You're using a handpiece, which you use all the time and you're super used to. Okay, you break through your contact. And because of the tapering that occurs with this burr, it helps maintain the embrasure. Right, there's our IPR done, an exact perfect 0.4. I don't use the leaf gauges to measure my IPR. I just literally do the thickness of the burr, and there's 0.3, 0.4, and 0.5 for those burrs. Hence why you'll never see me doing 0.2 on my clean checks. Here's what it looks like in real life. So you need to make sure to use water. I start here and then the water's not turning on, so I stop to figure that out. So make sure water is on. And then I'm starting at a 45-degree angle. Right, I'm just breaking through the contact. There's one point done. There's the second position. A little bit of gingivitis, so a bit of bleeding, but nothing too crazy. Break through our contact again. And the worst case scenario, usually with the burr itself, that can happen is that it could break. So you're gonna see it's gonna break here. I'll pause it so you can see it's a little bit shorter right there. This burr actually broke. Now what's that mean? Not a big deal, teeny little piece. You take a piece of floss, you floss between the teeth, you get that little broken piece out. You can even suck it up. Like look how big the actual the saliva ejector is in comparison with that burr. It's the smallest little piece. It's 0.4 millimeters in thickness. So you just use a little piece of floss it out, or suck it up in your saliva ejector, grab a new burr, keep going. So that's essentially how this burr works. It's beautiful. I often show this patient's case at the same time because she's the patient that I just showed in that example after we had straightened out these lower incisors. So we straightened them all out. That was my IPR. That video is 45 seconds long. That IPR, other than the fact that I needed to grab another burr and just zip between the teeth, took me about 1 minute. That's how long IPR will take if you're doing it effectively with the right tools. You're welcome. No. Yeah, I love the burr. It's amazing. It's changed the way I practice so much. I don't want you guys to be terrified of IPR. It's not something that has to be scary. You have good hand skills. You know how to use high speeds. I have full confidence that you know how to do it well. The thing is, though, you have to make sure the contacts are derotated. If you use that burr and you're going between these contacts, the sides of the burr where it tapers up, it's going to inadvertently hit something that it's not supposed to hit, right? Because the contacts are not clean. Like, they're not good. They're not interproximal. You're actually taking off the lingual of one tooth and the buccal of the other. So you need to make sure that you have the contacts derotated first. Okay, so that wrapped up our first two clean checks. That's how you do the IPR. So here's where we're at after our first round of trays. Most of our attachments are pretty good. I'm happy with them, but you can see that now the canine has started to erupt. And I need to extrude that canine and I need to rotate the canine. So this tooth needs to rotate in with a mesial in and a distal out, and I need to extrude it. The attachment design that I'm gonna do here is creative, it's different. It's not something that I normally use, but I did something a little bit unique. I actually placed two attachments, right? I place a 4mm and a 3mm, and I blend them together to create what's called a mustache. attachment. Christian Fournier taught me this one out of Montreal. So the idea here is that you have two surfaces for pushing on. Now, do you have to use this attachment in this situation? You don't. You could just use a 4mm conventional at this angle, just get rid of that one 3mm attachment and you'd get some rotation and extrusion. But I really wanted to make sure that extrusion occurred. I knew that this attachment here in this orientation would be good for my rotation. So let me just go ahead and show you here. So like this surface right here is great for pushing in rotation, right there. Just do this, give you a proper arrow, right? So I know that I have good rotation occurring and some extrusion, but by placing that second attachment, I've actually given myself the ability now that I will have extrusion occurring as well in this direction. So we have more control over the tooth with that second attachment. Again, do you need to do that? No, not necessarily, but is it something that you could do? Yeah. How you can ask to get those two attachments? I just told the technician to please place two attachments on the buccal of that tooth, and then I moved them around myself. It's too hard to try to get them to put them in the right spot. So I just said, give me two 3mm attachments on the buccal, and then I took control, grab it, move it, blend it. All right, and actually part of the attachment, I never realized this before, but part of the attachment actually fell off during that treatment because there's only one there at refinement. So part of it did not stay. So here's where we're at the end of the next batch of trays. This tooth has extruded, it has rotated. For the most part, it might need a little bit more rotation, but what I notice is my issue with this ClinCheck right now is that I do not have enough buccal root torque. Compare the difference between the 1-3 and the 2-3, the upper right and the upper left central, or canines. The 1-3 needs a lot more buccal root torque. I put some in here, but I need to put more in. I need to take more of that. So if I was to put more buccal root torque in, I would use the 3D controls. I would click on this tooth. So if you hover right over top of this one, you can see on the right side, right beside my mouse cursor there, it's saying root torque, buccolingual. So that's the root torque one. So I'd click on this and I'd pull the root towards the buccal. And maybe I'd go ahead and on the 2-3, the upper left, I would go ahead and I would reduce that a little bit. So that's how you can physically go ahead and do that movement, but I don't have enough of it. And that's gonna come back at the end of the case here. You're gonna see that she's really happy with it and doesn't wanna keep going when I notice it. The buccal root torque is not as ideal as it should be. But here's where we're at after our next round of trays. This round of trays is just help settle the bite. The question that came in before was, what do you do when you don't have a nice settled bite? I'm gonna go back one ClinCheck here, actually, one round of trays, and you'll see that, remember we talked about my bad expansion attachments there, that they should have been better, either the optimized ones or conventional attachments that are beveled to the occlusal? Well, the expansion didn't fully occur. When you look at these teeth from the back view, you can see they're kind of hitting cusp to cusp. And so we need to do more expansion and a little bit of constriction on the lower. I also would benefit from actually removing some of these attachments potentially and placing new ones at this point, or just taking a burr and making them more crisp, right? If I just took a burr and I just cut into this attachment here, kind of cut out some of this extra composite that's there, it would make a nice crisp surface again. Do the same thing on this one here, just get rid of this flash. And that would allow me to ensure that the root's gonna move with the tooth more consistently. Now, despite that, where we're at this point is we are hitting a little bit heavy on our palatal cusps. What I do a lot of in our office is I use some trays with minor movements just to settle the bite and no attachments at the end of treatment. So our left side is pretty nice in terms of its settling. Our right side though, we are propped open a little bit and we need some settling to occur. You can see the settling movements happening. And so at this point now, the patient's not wearing their trays full time. I call these my temporary retainers. They're just aligners, but there's no attachments and they're no longer, this patient was never eating with her trays in. She's taking her trays out and only leaving them in for maybe like 18 hours a day. So they're coming out a lot more. So this is where she was at the end of that batch before this ClinCheck. And at the end of this ClinCheck, after 6 months of just letting the teeth settle, a little bit of constriction on the lower, a little bit of expansion, allowing those teeth to come down just with time, this is where she's at 6 months later, from here to there, right? Did she have a premature contact in the anterior? Did she have a premature anterior contact? No, she doesn't. We did the IPR on the lower. We used some class 3 elastics. She's not hitting prematurely from lack of intrusion of those teeth. She has a nice flat curve of Spee, right? What are the main two causes of posterior open bites? Failure to intrude the lower incisors. You'll never make that mistake again if you put the right, strong, retentive attachments on the premolars and you overdo that intrusion. That's number one, failure to intrude the lower incisors. Number two is not addressing the Bolton discrepancy. In this case, we've addressed both of those. So now if we have a posterior open bite, Well, we just need these teeth to settle. We need them to come down. We might be hitting a bit heavy on the palatal cusp. So a little bit of expansion on the uppers, an extrusion, a little bit of constriction on the lowers, and mostly just some time. 6 months of wearing these trays, maybe 16 to 18 hours a day as retainers. And then at nighttime, you could even move just straight to nighttime at this point. 9 times out of 10, you're going to come back. You're going to see the exact same thing that we see here, which is those teeth have extruded into a nice full contact. Teeth will always have a tendency to super erupt back into a full contact. I intruded my second molar once just for the heck of it, just to see how much I could intrude. I intruded at like 4 millimeters and distalized at 3 to 4 millimeters. And then I just cut the tray and I just waited, and within 4 months it mesialized and it super erupted into full occlusion. Teeth have a tendency that they want to touch, and they want to touch in full occlusion. So I just don't want you to subscribe to the myth that having a posterior open bite is this horrible, terrible, no good thing. I guarantee you that orthodontists and me, probably 20% of my patients right now have some type of a posterior open bite from the thickness of the plastic being between their teeth. I'm not worried about it as long as I make sure to address those main issues. Okay, so this is where she's at once we are at the end of treatment. So midline's looking pretty good. Nice intercuspated, interdigitated occlusion. We use those class 3 elastics to make sure she didn't overshoot the target. We did some IPR on the lower. We let the bite settle. Nothing that was done in this case is extraordinarily complex, to be quite honest with you here. Once you know these techniques, and you're not going to learn them all in a 2-hour webinar, but once you know these techniques, then you know it. You can do it. It's just putting all the little pieces together. So I know that you guys can make this happen and that you can do this. I don't want you to be so scared and have paralysis by analysis and not do any treatment. Make sure you're treating within the comfort zone that you have. We want you to help expand it. We're here for you with that. We've got ClinCheck reviews with Kelly Terrell, myself, and Terry. We help with those. There's so many doctors who are taking advantage of that to help push their comfort zone into cases they otherwise wouldn't normally treat. Right? Go to our website, clearlyaligned.ca, find the ClinCheck reviews, buy a package. Again, if you're ever unhappy with it, we'll give you all your money back. I can guarantee you won't be unsatisfied. We'll help walk through ClinChecks, going through all this kind of stuff with you so that you see it on your own cases and you make money while you're learning. So we've got you covered.